next session is epidemiology, outcomes, and survivorship. Our first presenter is Dr. Jerome Razanamahery from Dijon University Hospital in France. His abstract today is entitled Early Changes in Intermediate Monocyte Distribution Correlate with Relapse-Free Survival During Follow-up in Adult Histiocytosis.
Hello everyone, it's a pleasure to be here to present this work about changes in monocyte subset distribution and relapse-free survival in patients with histiocytic disorder. So we know that histiocytic disorder are characterized by tissue infiltration by CD68 plus histiocyte among other inflammatory cells. Right now we know that several drugs can provide robust and durable response. The response is now assessed by imaging, mostly PET-CT and MRI when it's necessary, but right now there is no circulating cell correlating with disease activity or disease progression. We have talked about it earlier, but there is a role of the monocyte in histiocytic disorder because what is shown on this paper is that they can carry the BRAF mutation, and what we know is that the classical and intermediate monocyte can infiltrate the tissue and become the monocyte-derived tissue macrophage. So based on that, on the clinical practice, you can do some cytometry protocol, really simple, to see the monocyte from the white blood cell, and then have the different subpopulation based on CD14 and CD16 expression, and you can have the result in 1 day or 2 days, depending on your lab. So based on that, we try to make a study, a 1-year prospective study, based on the physical examination of patient, the PET-CT, and all the blood sample with standard biology, flow cytometry analysis for monocyte and lymphocyte, lipid test, C-reactive protein level, and VEGF-A. So this is the characteristic of the patient that we have enrolled. We have a total of 19 patients. Most of them was L group histiocytic disorder, mostly ECD, some LCH. Most of the patients had multicentric disease, and the most frequent mutation was BRAF, followed by MAP kinase pathway mutation. You can see here, during the follow-up, 12 patients didn't experience relapse and 7 experienced relapse, and they were similar at the beginning of the study regarding those characteristics. So this is the table of the characteristic of the patients. And right now what we see is that the patient who experienced relapse was ECD patients and LCH patients. There was no relapse in patients with Rosette-Hoffmann disease. So what we have in inclusion is that patients who had a metabolic response when they are entering the study, they have a lower amount of intermediate monocyte subset, and they also have a lower CRP level. So that's the result that we have here. So maybe this is important to look at these different subset of monocytes. We're going to talk about it later. At the inclusion, if you look at all the characteristics of the patients, there was only one thing, is that patients who experience relapse were more frequently treated by conventional therapy prior the inclusion in this study. At 6 months, there is only one difference. This is that patients who experience relapse have a lower lymphocyte count. This is what we see here, and there was no other difference regarding all the blood sample. And at the end of the study, if you look at all the characteristics, there is no difference. But the most important thing is that with all the patients, we made a longitudinal analysis, and the only thing that was associated with relapse-free survival was the early decrease of the proportion of intermediate monocytes, and there was no other important important dosage to notice on the study. So based on that, we think that it's based on the ontogeny and the role of the intermediate monocyte subset in patients with histocystic disorder. So if you look at here, you've got the CD34 plus hematopoietic stem cell who can have BRAF mutation. Then they go into the blood circulation to become the classical, the intermediate, and the non-classical monocyte who can have the BRAF mutation. And what we know is that classical monocyte and intermediate monocyte can go into the circulation and become the tissue macrophage after a stimulation with GM-CSF, IL-4, and there is a collaboration with dendritic cell via notch lineage. And when they enter the tissue, there is two environments in the tissue to promote the macrophage M1 phenotype or the M2 or M2-like phenotype, and maybe it's based on the level of IL-12, because when there is a stimulation with IL-12, there is an activation of this M1 phenotype macrophage who can, there is production and a discussion with the Th1 cell who can provide higher amount of TNF alpha, interferon gamma, and you have also stimulation of NK cell through IL-12. So with this M1 phenotype, you've got increased antigen presentation capacity and the killing of pathogen and tissue damage. And if you look at the low IL-12 environment, there is a negative feedback of the Th1 response with PD-1 and PDN1, and you've got an interaction with the Treg for immunoregulation, and you have a promotion of Th2 response with a lower amount of TNF alpha and IL-1. So maybe based on the environment on the tissue and the production of IL-12, you can have look like killing pathogen and tissue damage in patients with active histocytosis, and those with M2 and M2-like phenotype with response to therapy. And what is known is that the intermediate monocyte produce higher amount of IL-12 than classical monocyte, so maybe they can promote a switch into M1 macrophage phenotype, and that's why patients with metabolic response have a lower amount of intermediate monocyte. What we have on the correlation model is that LCH is negatively correlated with relapse-free survival on this cohort, and there was no other thing of interest. So there is some limitation and further direction to take. We know that monocyte subset is variable and can be modified by sepsis or worsening of an hemopathy, which can occur in patients with histocystic disorder. We have to look at the IL-12 enriched environment in the laboratory test by blood sample and on the tissue analysis. And one other question is, can drugs modulate the monocyte subset distribution? So to conclude, I say early decrease of intermediate monocyte is associated with relapse-free survival in patients with histocystic disorder. Repeating cytometry can be effective in relapse prediction, and of course, we need collaborative effort to confirm those data. So I want to thank everybody from my team in Dijon University Hospital, all the team in Pitié Salpêtrière, and Jean-François Emile for the analysis of the molecular pathway on biopsy, and of course, all the patients.
The abstract is open for questions. Any? Maybe I have one. So I think, thank you for showing the relevance of the monocytes subsets here. I understand that some of your patients got chemotherapy.
Yeah.
Did any of your patients receive like cladribine, which is a very potent monocyte, anti-monocyte drug?
No, they have vinblastine, but no cladribine.
No cladribine.
No cladribine.